So Dr. Roth is coming here from Jamaica Hospital to present to us. He got he was a physician assistant certification from Touro College in New York. And then he went to New York College of Osteopathic Medicine and got his Doctor of Osteopathic Medicine. He did his internship at Coney Island Hospital and then a family practice residency at Jamaica Hospital. And he then served as chief resident in the Department of Family Practice at Jamaica Hospital. So he has been the chair of the Department of Family Medicine and Ambulatory Care and Community Medicine at the Medicis Health Network and Jamaica Hospital Medical Center. He is also chief of the Division of Integrative Pain and Palliative Care Medicine, again at Medicis Health Network and Jamaica Hospital. He has done incredible scholarship, presenting for many years and publishing in family medicine. And he has a new book, A Return to Healing, Flexner, Osler, and How American Medicine Went Astray. And he's going to speak on that today for us. So thank you, Dr. Roth.
Thank you for your kind introduction, and thank you for inviting me. So yes, I wrote a book with a colleague of mine, Andy Lazarus. Andy is a graduate of Einstein, as long ago as I'm a graduate of NICOM. We met about 20 years ago at a Lown Institute conference on over-testing, over-treatment, over-diagnosis, and how it leads to kind of poor health care. So the book kind of evolved over us talking for those years. And we write a column together in American Family Physician called Lown Right Care, which comes out about every 3 months. And it's all about overuse of the healthcare system and, kind of how that overuse leads to bad medicine. In the book, which I think is important, we did a lot of research on the history of medicine. If folks don't know who Osler is, and if folks don't know who Flexner are, those are two folks that actually shaped the healthcare system that we're in. And a decision in 1911 called the Flexner Report kind of shaped how medical education is and the practice of medicine is today. One that is based on not really person-centered care, but one that's based on numbers and treatments. And we'll talk today about, how I think our healthcare system went wrong and what I think we could do to fix it. So to me, everything about fixing healthcare is about meeting the quintuple aim of healthcare. I'm sure we've all heard of it, about improving the healthcare experience, improving the health of populations, reducing costs, and certainly improving the provider experience, which is important for many physicians that are just kind of at the end of the ropes of how things are, and certainly improving the equity and access for everyone. So the book kind of goes and travels the history back to 1911 of medicine and kind of how the human side of healthcare got lost. And it's a historical perspective, as I said, going back to 1911, coming into kind of the current times. Every time I give a talk, unfortunately, though, the data that I present in the book, which was completed about 2 years ago and published this year, gets worse. The costs go up, the satisfaction goes down, and our life experiences decrease in the healthcare system that currently exists for us, and there's a tremendous need for a change of that. So the way medicine is currently practiced was very much thought out by Flexner. This report, as I said, came out in 1910. And some of the bad things that happened as a result of that was kind of a industrialization of medicine, but by what we term the medical industrial complex of insurance companies, the hospital industry, big pharma, device makers, and some of the medical colleges that actually represent some of us, like the American Medical Association and others. The divide that happened at Johns Hopkins over 100 years ago still exists today. And in our opinion, we have a healthcare system that has deviated away from primary care and shifted to specialty care, and has relied very much on testing and numbers rather than patients and their autonomy, and treating patients in a very patient-focused way. So we'll talk again about Flexner and Osler a bit. For the folks at Jamaica, they know I am a big Osler fan. And actually, when me and Andy met, he was the first person at a talk that I saw quoted Osler. And I was quoting Osler for my whole career because he truly is the father of medicine. As he states here, the practice of medicine is an art, not a trade, a calling, not a business, and a calling in which your heart will be exercised equally with your head. Um, Osler actually created the field of internal medicine 100 years ago, one that was truly based on science and evidence, but he felt that that science and evidence shouldn't be taught at the bench in a research lab, but should be taught in a doctor's office or at a patient's bedside. And that's where Flexner and Osler deviated over the time. In addition, Osler created our current system of residency programs. He created the first house staff system, and in a way developed the primary care versus specialty care model, which was kind of deviated in a negative way by Flexner, who looked at this as a simple numbers game. And we'll talk about those numbers as we go away, and how the art of medicine has gotten lost into the evidence-based science, which I'll talk about. We all believe in evidence-based medicine and science, but unfortunately, the evidence-based medicine is not necessarily evidence-based, and we'll talk about that. As I said, me and Andy met at a Lown Institute conference. Bernard Lown, another amazing man like Osler, who was very much into patient-centered medicine. Dr. Lown, I was fortunate enough to meet at one of the first conferences I went to. He was a well-known cardiologist, known for actually inventing the defibrillator. And the whole Lown Institute Right Care Alliance evolved from his viewing of his defibrillator being used to resuscitate people from non-cardiac diseases who shouldn't have been resuscitated. And we see that going on in our hospital systems every day, and it goes on today. So Lown and Osler were very much like physicians. He wrote a book called The Lost Art of Medicine, The Lost Art of Healing, and talks very much about the art of medicine and how the art is so important. To me, for every physician, it is a must-read book. For the learners in the group or the attendings, if you haven't read it, it is so important in its perspective of medicine. And he talked about, deviating from that patient-centered approach. And he's, like I said, a cardiologist, and that we need to go back and focus on the patient, because the patient is going to tell us what their problems are. So shifting from the good guys to what I call the bad guys, and I do feel Flexner is one that kind of screwed up our system. Flexner was a German-born educational specialist, not a physician. And he believed strictly in numbers. He believed that a medical school and patients were labs and should be treated that way. And he formed strong alliances or early on between the American Medical Association, academic societies, pharmaceutical companies, the hospital industry, and kind of stressed taking medicine away from the community. And I stress going back to the community that we serve. And I know, the Maimonides Einstein philosophy is the same as ours in Jamaica. Philanthropy got very much involved in this, donating at that time millions of dollars to look at how the healthcare system was, how the educational system was, and how it evolved, and essentially put Flexner, a non-physician, in charge of how medical education, subsequently residency education, and worse, how healthcare should be delivered in this country. Okay. The goals and objectives were clear and important, but not followed in a way that I think they were meant to be. It was meant to standardize medical education across the nation. It was meant to eliminate substandard medical schools, raise the prestige of the medical profession, and promote science, research, and innovation. And it did do that in many ways, but it also took, unfortunately, the patient out of the equation. And there were many ramifications of this, including the closure of most of the African American medical schools, the removal of women and Jewish physicians from medical education over the years. It merged academia, as I said, with the medical industrial complex and set the course on its path 100 years ago and more to what we are today. Another one of the kindred spirits of Osler and Lown was Einstein. Okay. Einstein actually believed that strictly using numbers in any part of science was wrong, and that rote memorization of facts was useless, that you needed to think about things, you needed to develop plans. And in medicine, that includes things like putting the patient first and developing a differential diagnosis and having a patient-centered discussion that is lost in the Flexner Report and how we deviate. So we truly treat people today like numbers, okay? Humans are not just numbers. Humans are individuals. So if you have a study that says X is true, well, it's true in a majority of the population, but it's not necessarily true or likely to be untrue in the patient that's in front of you at that time. It has enabled us to create what we call fake diseases, okay? Prediabetes didn't exist 20 years ago. We now treat prediabetes with medications like we treat diabetes, with little evidence that it has any true effect on the patient's longevity and well-being. We do screening in the same way. We don't deviate screening for who should be screened from just screening everyone. If you screen people that have a low likelihood of having a diagnosis, they're going to have a lot of false positives in there and a lot of extra testing that doesn't need to be done. So we call the numerical epidemic things like blood pressure and sugar and osteoporosis screening and LDLs and kidney disease. We know that all of these parameters have changed drastically over the last 50 years, with tighter and tighter and tighter control being asked for. Yet an article was just released in JAMA several weeks ago showing the number one cause in our elderly is falls. And why are our elderly falling? Because we're giving them too many drugs, and we're lowering their blood pressure too much, and we're lowering their sugar too much, leading to these things. One of our favorite researchers, both me and Andy, is John Ioannidis. John Ioannidis is a researcher who actually studies the studies. And in several landmark papers he has come up with, he has shown that 40% of all studies that we see as facts are refuted or even reversed in a few years. He reviewed that 97% of drug studies are actually funded by the drug companies who were there to promote their drugs. And most of the endpoints of these studies are numbers. So we see when the endpoint of a diabetes study is just lowering the sugar, we may do a good job lowering the sugar, but as we've seen from medicines that have been removed over the years, we may do a bad job of making someone live a longer or better life. Less than 9% of clinical trials of drugs actually demonstrate a true significant treatment effect. And 90% of the benefits of most studies are actually less effective than the study shows on subsequent studies that are not funded by those pharmaceutical industries. Okay. So we need to go away from just looking at patients' numbers, and we need to go back to the patient, back to the doctor's office, and back to the bedside. One of the things that bothers me the most when I have the residents and students in the office with me is we can't get through a visit without an app. And apps are beneficial. But I challenge folks to say, how many people have read the research behind the apps they're using? And what are the true benefits of using that app and formulating numbers and giving people more diagnoses that may or may not help their longevity? As I mentioned with the falls, it's interesting to note that the United States is the only nation in the world where this falls are increasing. The rest of the world, which uses much less medicine than we do and pushes the parameters much less than we do, lives much longer than we do. We overuse screening tests like the Apple iPhone to diagnose AFib. I'm sure we've all had patients that have come in and said, my phone has told me that I'm in atrial fibrillation. And we now end up putting patients with atrial fibrillation who have absolutely no risk for coronary diseases, who have negative risk scores, actually being placed on medications to slow their heart rate down and anticoagulants that could lead to real damage. The same is with cancer screening. I love the analogy of the turtles, the rabbits, and the frogs. Turtles are indolent cancers that will likely never kill you. Rabbits are actually the treatable cancers, which if we screen for, like breast, colon, and some of the lung cancers, we will pick up early and save lives. And then there's the birds. Those are the ones that, unfortunately, we pick up too late, like ovarian and pancreatic, and we don't have a tool to measure them. So any screening for those cancers, and we know people screen for ovarian cancer with pelvic ultrasounds and CA-125s with absolutely no evidence that it does any good. And this is actually harming the nation that we serve. Okay? And the fault, in my opinion, is the medical industrial complex. Why is it the fault? Because we have come up with a healthcare system that is based on profits over patients, one that is based on specialty societies dictating who earns what, how much people earn, how much people are paid for tests, and unfortunately, how much people are paid for the time in the office that they spend with the patient. Big Pharma has essentially penetrated every single area of our healthcare system, including the Food and Drug Administration, the CDA, all academic research, Congress through the lobby groups, media through advertising on television. We're one of only 2 nations in the entire world that allows advertising on television. It makes absolutely no sense to advertise cancer drugs and other immunomodulating drugs and diabetes drugs on TV. It serves, in most people's opinions, no purpose, and most of the world agrees that there's no purpose to it. So we need to go back to true medicine, and true medicine is based in primary care. And I'll shift as the talk goes on why primary care is so important and why we need to change to an emphasis that's one on well-being, prevention, and integrative approaches to wellness and health. Because the Flexnerian philosophy led to the death of primary care. It led to the shift of money going away from primary care. We only spend 5 to 7% of our healthcare dollar on primary care, with 95% being spent on hospital, specialty care, and pharma. And early 2025 data has come out already, as I said, every time I give a talk, and it's down to only 4% of the average healthcare dollar that is spent on primary care. Osler said early on, it's not about the drugs we give. If you give someone a drug, now you have two problems, the problem and the drug. And we know that so much in the drugs that we give. And we need to think twice about the polypharmacy that we're doing in this country that may be hurting people in some instances more than helping them. We live in the most unhealthy country in the world. Our life expectancy is decreasing because of obesity, physical inactivity, tobacco use, lack of safety in our communities. We need a better understanding of what causes disease, okay? The genetic components, the social, the environmental, and the individual determinants of health. And we need a strategy that goes to prevention. Strategies and actuarial figures that show that if we invest in prevention, we will meet the quintuple aim of healthcare. And I hate to tell everyone on this, only what we do as physicians affects 10 to 20% of longevity. These are the things that we do to people, not for people. The tests, the procedures, the medication only affects longevity by 10 or 20%. It is about the genetics, the individual behaviors, and the social and environmental factors that makes us live long and healthy lives, and why so many countries in the world live so much better than us. Our hospital system is a total disaster. There are mergers, acquisitions, closures. Rural healthcare is taking a beating. I will not talk about the big, beautiful bill in this talk. It's past the talk, fortunately, but we've already started writing about it and how it is going to kill the healthcare system in our country. We talk about the academic healthcare centers, where is the mecca of amazing care. Well, the mecca of amazing care costs 20% more, with higher hospital-acquired infections, higher rates of medical errors, higher length of stay, and higher mortality rates. Hospitals are estimated to be the third leading cause of death in the United States of America. The United States is the only country in the world that truly has medical malpractice. The United States has 5% of the world's population and half of the world's lawyers. The United States has 30% more lawyers than it does doctors, and defensive medicine is estimated to cost $125 billion annually, leading to overtesting, overdiagnosis, overtreatment, and needless worry, complications, and deaths to patients. The United States is one of the only nations in the world with medical bankruptcy. Medical bankruptcy is the leading cause of bankruptcy in our nation. It doesn't exist in most of the world. And this is in patients, many of whom who have health care insurance because of high copays, deductibles, and co-insurances that's bankrupting our nation and is bankrupting individuals. Big pharma keeps getting bigger and bigger, and the United States keeps paying more and more of it. We cover half of the world's pharmaceutical costs. The pharma lobby is $300 million annually. Most drugs to market are repaid in the cost of a drug in 1 to 3 years. And the pharmaceutical companies are spending literally most of their money on advertising and marketing to physicians. Unfortunately, there are many physicians that are doing very well on this. ProPublica, which, kind of the precursor to the Sunshine Act, which monitors how much money physicians are making, shows that pharma is spending billions of dollars on physicians. There were 2,500 physicians that received $500,000. More than 700 physicians received more than $1 million. You can't tell me that their work is unbiased. That money doesn't include research and grants. So the system is literally bankrupting our nation and our patients one sickness at a time. And it needs to end. Medicare, which was formed in 1965, was felt to be the answer to the rising costs of the 50s and 60s. And Medicare was a monumental act, which came out in 1965, providing health care for all Americans age 65 and over, and expanded the Medicaid program so people had access to care. Unfortunately, what ended up happening is it was kind of taken over by the American Medical Association. If you look, every time you drop a bill in the computer system, there's a little AMA thing about the ICD-9 codes and the billing and coding rates, which are monitored and maintained and overseen by the American Medical Association. The shift in Medicare took healthcare out of the office and into the hospitals and replaced patient-centered care with technology and high-volume care. We are a sick care system. If you have a heart attack, if you get shot, if you have a stroke, this is the best country to be in. We do great acute care. We save more lives than anyone else. Unfortunately, we waste more money than everyone else. We waste trillions of dollars on medical waste, fraud, and abuse. Our healthcare providers are spending half of their time at their desktop. We know that so few are eating up all of the healthcare costs. 5% of patients accounting for 50% of the costs, with a third of that in their last year of life, and most of that in their last admission to the hospital, getting testing and procedures that are unlikely to help these individuals at all. It is just a dysfunctional mess. And where is the money going? The money is not going to us. The money is going to the hospitals. It's going to pharma. It's going to device makers and other clinical services, with the physicians and healthcare providers taking up the smallest piece of the pie, and those of us in primary care getting even a smaller piece. So little is spent on primary care. As I mentioned, the amount invested in primary care goes between 4 and 7 or 8% over the last 20 or 30 years. And it is not improving, it's getting worse. And many states are worse. New York, as you could see in the peachy orange here, is one of the least states that invests in primary care. And it's estimated in New York, it's about 30% of what we spend on primary care, because we're spending all of our money in the academic healthcare centers. The CDC is funded by industry. The CDC, who is funding research, is funded by industry. It doesn't work. The system can't work. The system needs to be exploded and overhauled. And I must mention, because a lot of our research went back to this, we created a racist healthcare system and a systemic racism in healthcare that still exists today and will take years to fix. The AMA in 2008 had to issue a public apology for essentially killing black medical care physicians in this country for pervasive bigotry over the years. They removed women from medicine. Okay. 5 of the 7 black medical schools closed. The only ones that remained were Meharry and Howard during that time. A century later, we look, the proportion of black physicians was 2.5% with those medical schools. It's pretty much the same now. Some recent data is showing small upticks in underrepresented minorities in medicine, but certainly not to level out with the populations that we serve. They literally wrote in these documents that black doctors continue to contagion in our country, and that black doctors' role at the time should be for the prevention of diseases from blacks going to whites. This is written and barely talked about. So I'm going to shift to where we are in the healthcare system today. A lot of this is based on a report called Mirror, Mirror, the Failing of the U.S. Healthcare System. And what I'm going to tell you is our healthcare system, especially with the big, beautiful bill, is about to self-implode within the next few years because the rising costs are simply not sustainable. We rank last in almost every performance measure in the world, from access to efficiency, to equity, to outcomes. Our primary care workforce is shrinking. Trainees entering primary care is shrinking. We underinvest in primary care. We invest in high-tech technology, but the technology for users in primary care, our EHRs, are not effective like the technology used to open a clot in someone's heart or brain. The FDA and the CDC don't invest money in primary care research. Most of the studies that show primary care is the answer to our healthcare system is 20 and 30 years old. There are certain facts that we need to mention here. Our healthcare system is unaffordable. I've been giving these talks about our healthcare system for many years, and every year the cost goes up. Every year the percentage of our GDP goes up, and it would make sense if we had the most longevity in the world and the best access in the world, but we don't. We don't have the best. We have some of the worst. Our life expectancy is 46th in the world. Our infant mortality rates are 50th in the world, and we have the worst healthcare disparities of most nations in the world. Asthma death rates, diabetes death rates, infant and maternal mortality. It's simply unacceptable and the truth. Many patients don't even have access to a meaningful primary care doctor, or if they do, it's in a center where they see a different provider every single time. Why is this happening? It's happening because of money. Our medical industrial complex is sucking up the money. The health insurance industry, the hospital system, and I hate to say the associations that back them up. The American College of Cardiology, whose doctors are making $1 million a year, do not want to see a change in how healthcare is funded. They don't want to see decreased payments for procedures and increased payments for the doctors in the office visit. And unfortunately, much of primary care is being bought up by venture capitalists, where they come in and start that you're going to see 12 patients a day. And after their systems are fully implemented, those numbers double. And the incentives go back to, units of RVUs that don't measure anything about what a primary care doctor does. The lobby dollars that are sucking up and being spent on Congress are influencing Congress that they will never change this unless there's a total upheaval of the medical care system. The answer to our healthcare system is primary care. We talk about it a lot in the book, but the data shows that the answer to our healthcare problem in this nation is primary care. That if we invest in primary care, people will live longer, will have lower infant and maternal mortality rates, lower costs, and a more equal healthcare system for all. We know that continuity relationships improve diagnostic accuracy, care coordination, decrease ER and hospital visits, and help us meet the quintuple aim of healthcare. This is a slide from a friend of all of ours, Dr. Wayne Jonas and Alana Rosenbaum, who have written much about the advanced primary care model of care, taking it from standard care to comprehensive care to enhanced primary care to advanced primary care that takes the whole healthcare picture in and adds in a population health approach, adds in health equity, integrative care, and addressing the health-related social needs that our patients have. We have gone from a system that was based on primary care doctors to one where less than a third of the doctors are primary care. We went from a system that highly respected and paid primary care doctors to one that shifted away and shifted the focus to specialty care and hospital care. We need to change that. Policies need to change to make primary care a top priority. We need to be paid more. We need to be paid differently. We need to make it easier for people to access care and support the primary care physicians to make people want to go into primary care. We need to make true evidence-based investments use true policy and economic levers to prioritize primary care, to strengthen the trust that our nation has in our healthcare system, and remove barriers for people's access to care. We need to shift, and we hear it all the time, patient-centered care, shared decision-making, focus on the health of each and every patient. Let's talk less about calculators and more about what matters to the patient and the patient care, like most of the world does. Let's change from our current reactive sick care model to one that is more proactive, that focuses on wellness, health, a strong primary care foundation, one that patients have choice. We all need to advocate. If we do not advocate, we will not make the change. If those of us that are in primary care are not pushing this, no one's going to push it. Health insurance doesn't want us to change. The hospitals don't want us to change. Big Pharma doesn't want us to change. The AMA and the American College of Cardiology, they don't want us to change. They like this. We need to make primary care more attractive, okay? We need to have structured reform. We need to enhance the design of practices to meet the need of the patients, redesign EHRs to meet our needs, coordinate with health practitioners in mental health, integrative medicine, and nutrition. We need to create programs that those that already have loans get them wiped out. The system of, free medical school in certain colleges is great. But wouldn't free medical school and colleges for those entering primary care be better? That's where it needs to shift. We need to re-energize primary care. We need to recognize that that office visit is what is going to change people's lives and live longer and better. Medical education needs to be reformed. We need true mentors in primary care. It shouldn't be all in the lab and in the hospital. Okay? Okay. It has nothing to do with rat-based research. And most of medical education is being taught by researchers and not clinicians. We need to totally remove industry from healthcare. Industry is not making it fair. It's not leveling the ground, and it's not promoting primary care. Our industry doesn't want to see people healthier. That's less drugs, less interventions, less devices, less surgery. And the world has shown us that if we do that, it truly works. There can be no funding in our CDC and FDA. Consumer advocacy groups, which are telling people, you have an A1C of 5.7, you need to go on metformin. Who's funding those groups? The pharma industry, again. The TV advertising just needs to stop. It's helpful to no one, and it's causing the system billions of dollars that could be put into wellness, health, early detection, and prevention. Academia must have strict guidelines for separating it, okay? We need to be pharma-free from our hospitals. We need to be pharma-free from our research labs. And we need to be pharma-free from funding the projects that they are making projects to purely fund. Just showing that an A1C is better doesn't make a drug good. Just showing that a blood pressure is lower doesn't make a drug good. It shouldn't just be numerical outcomes. It should be true evidence-based on longevity, wellness, and health about the drugs we choose. We need to go away from the Flexner system of medical education and shift to patient-focused care that is not just about the technology we have. We need to go back to, as I said, office-based bedside teaching. Less resilience on the apps and more resilience on mentoring, bedside patient care, and office-based teaching, and talking about what matters to patients, okay? There is no one right answer to the patient in front of you. There never is. And an app saying that there is just wrong. It's based on an actuarial figure, and the underlying data may or may not be accurate. We need to recruit the right students into medical care that is diverse, okay? Broad-minded, humanistic, critical thinkers. Science is important. We need to change the MCAT exam to address that. We're still teaching rote-based medical education. We need to bring patient care into the office in the first year of medical school. okay, including research and scholarly activities and things like that. We need to go back to the art of medicine and go away from just technology driven, industry run healthcare system. This will not happen without an entire payment system reform. We need to stop paying for unproven procedures. Unfortunately, payments need to go down for those procedures, and payments go up for your mind and spending time and counseling patients. If we do, more young physicians will choose primary care as a specialty. There are multiple ways of paying for this. Value-based payment systems, capitated-based payment systems, direct primary care. And yes, there are direct primary care models that are not concierge medicine. It only takes $500 or $600 a year to pay for primary care. The numbers show it. So if we could have the Medicaid system to fund direct primary care, the Medicare system fund direct primary care, it would work. System changes could happen and save money and improve longevity. But I could tell you the medical industrial complex and our specialty physicians don't want to make it happen. And it's not going to happen. And Congress doesn't want to make it happen because it's simply too much money for them. And trying to explode the healthcare system is just too risky to them and their voters. Protocols and quality indicators have to change. How we're reviewed as a primary care doctor based on A1Cs and blood pressure results in the patients that we serve in Queens and the Bronx is simply not right and not fair. The recent study on falls shows that polypharmacy kills people, especially our elderly. Less is better many of the times. And we need to show that in how we evaluate. We need to move to one that is based on proactive systems of prevention, lifestyle medicine, removing unnecessary lifestyle medicine promotion, removing unnecessary treatments. We need to go away from the philosophy of do a test, diagnose it, treat it. We need to go back to talking about advanced care planning. So few people have any, and promote wellness, health, appropriate cancer screening and early detection. Immunize those folks that should be immunized. So, as Osler said, the good physician treats the disease, the great physician treats the patient who has the disease. I know you might be sick of him by now, but it is my life, and it's been my life for years. This is my quote that's in the book. The great primary care physician becomes part of a patient's family. We celebrate the achievements of life and grief, pain, suffering, and death together. What can be a more satisfying, intimate, and noble as a profession? And I mean that. And this is what we need to treat our young learners. We need to take our long learners, have them embrace the primary care model, and go back to primary care. Because unless we get the best providers, the system will not change. The system will only work if it's based on primary care with appropriate reimbursement and appropriate care. So we do have a website. If anyone wants to go to the website, it's called returntohealing.com. I think the book, sheds a lot of light on what's in there. We've gotten a lot of positive feedback. And as I mentioned earlier, I'm going to give a shameless plug for an organization that I'm a member of, and several other people are on here. There's no way we're going to fix the healthcare system unless we advocate for a healthcare system. And the only way it's going to happen is if we do it. And the only way things are going to change is if people advocate for a system based on that. And I'm part of an organization called Primary Care for All Americans. And we simply believe that if every American had a primary care physician, we would meet the quintuple aim of healthcare and our world would be a better place. So I will stop now, and I left about 10 or 12 minutes for questions as asked. So thank you.
Thank you so much, Dr. Roth. This is so important. And, you've combined a lot of things that we talk about and put it together in a really important summary. I'd like to open the space for people to either unmute and ask a question or comment or put that into the chat. The one thing I will say, you know, when I think back to whatever attempts we've had to change the healthcare system, I guess first with Hillary Clinton, with Obama, I thought there was such optimism about about where we could go, and then it seems like the the specialists, the pharmaceutical companies, the lobbyists, all ended up influencing what eventually came forth. I'm curious what you and I think maybe what you have here, this every American neighborhood and community, um, to get more grassroots support for changing healthcare, maybe the only way that we can make the change.
Well, so I agree with you 100%. Many attempts to change the system over the years, we've seen so many failures from the 80s and 90s. Family docs are just gatekeepers and they're here to give a referral. So, that did a lot of damage to our profession. Obamacare, yes, it got more people insured, but it didn't do really anything to change the delivery system. Payment systems, yes, yes, it covered some more primary care and preventive services, but it really did nothing to change the delivery system. The only way this is going to work is if we change the delivery system, and it's not rocket science. It doesn't really, it shouldn't cost anything. It should save money to one that's based on primary care. We know the only evidence that has been shown to improve longevity of our nation and in the world is primary care that is based on aggressive lifestyle modification, wellness, early detection, prevention. It works. We know it works. We've seen vaccines eliminate diseases. Yet, we see the fights that are going on. So I think there needs to be small changes. And I think as primary care physicians, if we don't advocate that everyone should have a primary care physician, because at least that would be the start. Because if everyone had I'm not saying, it's not about the evidence. It is about the evidence, but we need to make sure the evidence is real and not bastardized by the pharmaceutical industry and the device makers. Recently started reading all of the things about AFib and the devices. We really probably kill more people with anticoagulation than we help. And then shifting to the Watchman, if anyone hasn't read about the Watchman device, it is simply a joke. Like, there's an extremely high mortality rate with this device. Like, how it's not being investigated and potentially taken off the market of people having strokes on these devices is unbelievable. I've never said to one of my patients, you need a Watchman device. And, this is also all pushed by advertising, devices, and pharmaceutical. And yes, there's a place for it. Like I said, we have an amazing acute care healthcare system in this country. If you get shot, if you have a heart attack or a stroke, like, we're going to save you more than any other place in the world. But we do nothing to prevent you from getting there.
I see a question in the chat here. Primary care physicians refer most ailments to specialists. How will that change?
Not the primary care physicians that I work with. So we shouldn't be. Every primary care provider should be practicing to the full scope of, one, their license, but two, their clinical abilities. And in no means am I saying that specialty care is not necessary. I work in an office full of specialists. Specialty care is absolutely necessary. But we don't need to send a right bundle branch block in a healthy person to a cardiologist who's going to end up getting, an echocardiogram and a Holter monitor and maybe an equivocal stress test that leads to a useless cardiac catheterization. In fact, cardiac catheterizations and chronic stable cardiac conditions have shown to be useless, and that the only place it truly is beneficial is in acute coronary syndromes. So Those that are sending all their patients to specialists, then we need to re-educate those family docs. And I'm sure they weren't trained at Einstein and Jamaica or Monty in Jamaica because we don't train our docs that way. Okay. I would never send a type 2 diabetic to an endocrinologist, yet they're sent every day. It's totally within the scope of our practice. Okay. I don't know how to monitor and regulate a insulin device. So I'm going to send those patients that should be on insulin devices to the endocrinologist. So we have a place for our specialists. But every primary care physician should be treating high blood pressure and diabetes and hyperlipidemia and basic coronary diseases and the basic things we see every day and not referring them to specialists until either they've reached a condition they can't control, it's refractory, or it is a true specialty disease like advanced heart failure. Other questions?
Yeah, I just wanted to say that the use of specialists is very physician uh, kind of specific. Some physicians are referring all the time, like to an endocrinologist. And I think it's up to us to teach what, the scope of our practice, what we really can do, and to make sure we do that. Um,
So I agree with you 100%. Let me give you a story. So Dr. Tulo, who's on here, who's my vice chair, did a study last month. We looked at the referral patterns of our doctors because we wanted to see if we could cut down on some of the referral patterns. And I could tell you by far, and he could back me up, the biggest referrals to specialists are in two groups. One are our primary care internists who are
mm,
just used to doing it, and the other are our PAs and nurse practitioners.
mm,
And it's well documented in the literature. It's well documented that, NPs and PAs do expand the workforce, but unfortunately have significant higher rates of referrals of things that should be within the realm of primary care. And our primary care internal medicine colleagues do the same.
mhm.
Very high, like every abnormal EKG that is insignificant goes to cardiology, and, you know, type 2 diabetics going, to endocrine and stuff. We all know what endocrinologists are for and rheumatologists. And I have friends in every one of those fields I refer to, and they're important and needed, but not to deliver primary care.
There's another question in the chat. Could you comment on the trend to increase access to primary care focused on expanding apps, which often results in more referrals and
So
algorithmic?
I think the online apps and algorithms are horrendous. I think teledoc should be outlawed. We recently presented, this is a real case of a patient. This is a patient of mine that went to one of the prestigious Manhattan institutions that has a, virtual program for orthopedics. So we know there's two big hospitals in the city that have them. So I won't mention which one. And did a televideo visit for knee pain and leg pain. The patient, without being examined by the doctor, just, the quote, self-patient exam, was given an X-ray, venous Doppler, and MRI. Well, you need that if you're not examining the patient. You don't know if it's a knee sprain, a tear, or a DVT. So they just got sent for like $7,000 worth of testing with a clinician not touching them. How
Mm.
the insurance companies allow this is just mind-boggling to me, but it all adds to the bottom line. The reason the health, I didn't mention this, but the reason the health insurance companies allow this is their CEOs are only allowed to make a certain percentage of the profits that they have, And the more money they spend, the more that goes into healthcare, the more their profits, the more the CEOs make as well. So the system is just set up as, being on a hamster wheel that's going to keep going the way it is.
Exactly. And just, I think you spoke about this a little bit, but also, using advanced practice providers, and how much that, increases referrals and algorithmic care.
So it does. We do have advanced practice nurse practitioners at our institution, um, many of whom I would let take care of me because they've been here for 30 years and we train them. I don't know if the whole audience knows, but an advanced practice nurse practitioner could actually go and not even practice as a nurse. They could go from nursing school to get their master's, to even be a doctor and get their PhD. And all of those degrees only require 700 hours of clinical training. And those 700 hours are not standardized. So the 700 hours could be 200 of psych, 200 of ER, and 200 of, let's say, pediatrics. And they could have no primary care experience, no medicine, but they're graduating as a family nurse practitioner and could come out and, under supervision the first several years, practice that way. So what we do here when we hire someone like that, if we do, we put them into a precepting program, kind of like a mini internship or a mini primary care residency, because they're not prepared.
Dr. Roth.
Dr. Tulo.
One of the things that you brought up, I think also has to take into consideration is the fact that many of the doctors that did a lot of the referrals, the primary care internists, are really older doctors that still come out of the RVU system where, see a lot of patients, drop a lot of diagnoses, refer to a lot of people. And I think that having practiced that long in that way, because that's what the system required, sort of it's now harder to get them back into a quality-based approach. I know we've been working on that here pretty successfully, but the fact is, my question is always, how do we shift the mentality of these providers that were working in a system that we know is not based on quality, but just on numbers?
We need to continue to educate people. So it came up this morning in a review I was doing, cleaning my Epic in basket this morning. And one of my patients was sent to a neurologist by me for an appropriate reason. And instead of the neurologist sending the patient back to me, they referred to ophthalmology, ENT, and rheumatology. So we will be having a talk with our chair of medicine because it's another avenue for over referral. Specialists should be sending patients back to their primary care, or again, it continues this unnecessary referral pattern. Any other questions?
I have a question. My name is Dr. Marquez. I did my training in Connecticut in a community-based hospital, and I have found everything that you said to be very spot on. And it's more of in regards to just practicing in New York City, where we're so specialized heavy here. I feel like the first inclination you have any kind of uncertainty as a primary care physician here is to just refer to a specialist or to get further tests or to do this instead of kind of like watch and wait. And I really commend your talk. And I've gotten very frustrated because as a person who did cleaning training in Connecticut and coming here, I was frustrated because I have seen so many specialists refer to specialists. And I said, then what is the point of me, basically? And so thank you.
So thank you for your comments. And I agree with you 100%. The system is not working. It's not a primary care-based system. And unless we go to one, costs will continue to escalate. Our longevity will continue to decline. Like you could say, okay, the system is worth it because we're living longer and longer, but we're not. We're one of the few industrialized nations with higher mortality rates. There's so much inequity in our healthcare system. People are not getting great healthcare, except those that have a good relationship with the primary care physician. So the evidence is totally there, and it would save so much money. And no, I don't want to be a gatekeeper again, but a specialist who gets a referral from me needs to send the patient back to me, and not to another. And I decide, do they need those other 3 referrals, not the specialist. And they shouldn't be writing in their notes, because we all now know, well, now it's in the note. The neurologist said they need these 3 more referrals. And now the primary care provider, especially if it's an NP or a PA or a young physician, is going to say, well, I'm not going to override the neurologist. Like, he's a big professor here. I'm not going to do that. So, it's a broken system. It needs to be gutted and overhauled. And I hope it happens from the ground up, from primary care changing and people seeing it. I hope it doesn't happen because the system literally crashes, which many people are predicting with the big, beautiful bill.
Well, thank you so much, Dr. Roth. This has been so important for us to hear. I think we're on the same page, and just need to really move forward together. It feels like we're going backwards, but we
So
need to
yes,
keep our.
let me just add, please sign up for primary care for all Americans. It's free. We need people's numbers. We're going to be advocating in Albany, and the more numbers we have from New Yorkers, the better it is. And all you need to do is go there, your name, your zip code, and your email address. That's all we need. We do not need your money. We'll take your money, but we don't need your money. And we'd love anyone who wants to volunteer. My email is aroth@jhmc.org, aroth@jhmc.org. I'm happy to talk to you about the organization and how you could volunteer. But if you're a busy student or a busy resident or a busy attending and you can't, just giving us the numbers is important. We will harass you with a newsletter every 2 weeks, which I think are fabulous, that keep you up to date on these primary care issues. So please just sign up. And again, thank you for the invitation.
Alan, if you could put up your slides again, just to have that QR code, to make it easy for people to sign up.
I didn't take them down. Let's see.
Ah,
Oh, they're back up.
Okay.
They're
Slides there.
They're back up.
Yes.
I don't see them, but okay. Thank you very, very much.
Thanks for inviting me. Have a great day, everyone.
All right.
Bye-bye.
Bye-bye.